So let's talk about the diagnosis of pneumonia in general. The most important initial test for any type of pneumonia is chest X-ray. So the best initial investigation or diagnostic test whenever you are suspecting pneumonia is chest X-ray. Chest X-ray can show us feature of pneumonia, and along with that also chest X-ray can show us complications which can result from pneumonia like pleural effusion, empyema, or lung abscess. And the findings of pneumonia on the chest X-ray will depend on the organisms causing pneumonia, whether it's typical organisms or atypical organisms. Typical organisms, as we discussed previously, tend to involve the air spaces, and it results in filling of the air spaces with exudate. And this filling of the air spaces with exudate will give you the characteristic radiological finding of pneumonia, which is consolidation. So typical organisms will give you consolidation on chest X-ray. And this consolidation can be either confined to one loop or it can be involving more than one loop. When it's involving one loop, it would be called lobar pneumonia. So if you have a patient with pneumonia in which the chest X-ray is showing consolidation, which is confined to a single loop, to one loop, this will be considered as lobar pneumonia. So typical organisms will give you the typical radiological feature of pneumonia, which is consolidation. But if you have pneumonia due to atypical organisms, which is called atypical pneumonia, you will not have the characteristic consolidation, because the atypical organisms, it tend to involve the interstitium of the lung, and it usually spares the air spaces, and for that reason usually there is no filling of the air spaces with exudate. And this is why usually there is no consolidation in atypical pneumonias. And instead, when you have atypical pneumonia on chest X-ray, you might have interstitial infiltrates, which indicates that there is an inflammatory process involving the interstitium of the lung and sparing the air spaces. So atypical pneumonia usually will give you interstitial infiltrates, which tend to be bilateral in a lot of cases. So typical pneumonia will give you consolidation in most of the cases, especially in pneumococcal pneumonia, while atypical pneumonia will give you bilateral interstitial infiltrates in a lot of cases. Then along with that also, you can detect complications of pneumonia, as we said, like empyema or effusion or lung abscess. So chest X-ray is the best initial test in the diagnosis of pneumonia. But chest CT is more sensitive than chest X-ray. Chest CT can give you even more information. Chest CT can give you, can even sometimes it can detect bronchial obstruction, because there are some cases of pneumonia which occurs on top of some underlying bronchial obstruction. For example, there might be bronchial obstruction with a bronchogenic carcinoma or with a foreign body. And this bronchial obstruction can predispose to pneumonia. And this bronchial obstruction can be detected on chest CT. So this is an additional advantage which can be obtained with chest CT. So chest CT is actually more sensitive than chest X-ray in the workup for pneumonia. But still, chest X-ray is the best initial test in the diagnosis of pneumonia. Along with that also, it's recommended and it's advised, whenever you have a patient diagnosed with pneumonia, it's advised to repeat the chest X-ray after 6 weeks. Because, as we said, there are some cases of pneumonia which develops secondary to underlying bronchial obstruction. And one of the important causes of bronchial obstruction which can predispose to pneumonia is lung cancer. So it's important to exclude lung cancers in patients who are having pneumonia. And in the early presentation, in the acute phase of pneumonia, you might not be able to detect the tumor or the cause of bronchial obstruction. But after 6 weeks, when the patient has received his treatment and the condition has resolved and recovered, when you repeat the chest X-ray after 6 weeks, there is a chance that you might detect some bronchogenic carcinoma or some tumor causing bronchial obstruction. And it's one of the predisposing factors for pneumonia. So pneumonia, in some cases, it can be primary, or it can be secondary to some underlying lung disease. Then the next step, after diagnosing pneumonia based on the radiological features, the next step is to try to demonstrate and to isolate the likely organism causing pneumonia. But actually, we will not wait to confirm the likely organism, to confirm the cause of pneumonia. Whenever you are facing a case of pneumonia, after the radiological diagnosis, we will start empirical blind antibiotic therapy immediately. And in a lot of cases, in most of the cases, the patient will respond to our empirical antibiotic therapy, and we will not need to confirm the exact etiology of pneumonia. But still, it's recommended to do sputum gram stain and culture in order to look for the sensitivities of the organisms. Because if the patient didn't respond to the empirical therapy, then we can modify and we can adjust our antibiotic therapy based on the results of cultures and sensitivity. So after doing chest x-ray, it's recommended to do sputum, to take sputum samples for gram stain and for culture. But you will not wait for the results. You will start empirical antibiotic therapy. And if the patient didn't respond well to the treatment, then you can adjust the antibiotic therapy based on the results of cultures and sensitivities. But the problem is, in 30 to 50% of cases of pneumonia, actually, the organisms cannot be detected on gram stain and culture. Because remember, we said that there are cases of pneumonia caused by atypical organisms. And atypical organisms will not be demonstrated on sputum gram stain, and it will not grow on our standard bacterial cultures, and it will require special investigations. So there are a lot of cases of pneumonia, around 30 to 50% of cases, which will give you negative sputum culture. And in these cases, it's possible to diagnose these atypical organisms with special types of investigations. So atypical organisms will not show up on gram stain or regular bacterial culture for different reasons, and they will require special testing, such as sputum PCR. And in order to isolate or to demonstrate typical organisms, you need to do sputum for gram stain and culture. These organisms will be demonstrated on gram stain and culture. But atypical organisms will require special investigation. It will not show up on gram stain and culture. It will require either to do sputum PCR, looking for the bacterial nucleic acids, bacterial genome, or it might require serology, require special serological tests, looking for the antibodies formed against the bacteria. And in some cases, like in pneumonia caused by Legionella, we can confirm the diagnosis of Legionella by urine antigen tests. So atypical organisms will require special types of investigations. They will not show up simply on gram stain and culture. They will give you negative sputum gram stain and culture. And we can demonstrate these organisms either on sputum PCR or on serological tests, or by doing urine antigen tests in case of Legionella. But actually, in most of the cases of pneumonia, we will not need to do these investigations. We will just do chest x-ray to confirm the diagnosis, and then we can do sputum for gram stain and culture. And we will not need to do investigations directed towards atypical organisms, because actually our empirical treatment will include macrolide antibiotics, and atypical organisms are always sensitive to macrolide antibiotics. So these organisms are treated empirically. By giving our empirical treatment, which including macrolides, we will automatically treat these atypical organisms if it's causing pneumonia, and so we will not need to confirm the diagnosis of these organisms in most of the cases. Then there are other investigations which can be also performed in our workup for pneumonia. There are blood investigations. You can do CBC, complete blood count, which usually shows leukocytosis with neutrophilia. But in some cases, in atypical pneumonia cases, you might have lymphopenia instead of neutrophilia, especially in pneumonia caused by Legionella. Legionella gives you lymphopenia. And also in pneumonia caused by viral infections like coronaviruses, it will give you lymphopenia. It will not give you neutrophilia. And also in mycoplasma pneumonia, you might have an evidence of anemia because it's associated with autoimmune hemolytic anemia. Then also, as part of our blood workup, we can do blood cultures as well. Sometimes we can isolate the typical organisms on blood cultures. We can do also arterial blood gases, which can evaluate the severity of the condition. It might show us respiratory failure. We can also do renal function tests and liver function tests as part of our routine investigations. And as we said, one of the possible complications of pneumonia is acute kidney injury. So it's important to do renal function tests as part of our workup in pneumonia. And also we should do liver function tests because there are a number of cases of pneumonia, of atypical pneumonia, in which there is subclinical elevation in the liver enzymes. And along with that also, we can also do inflammatory markers. We can check the inflammatory markers, especially the C-reactive protein. And inflammatory markers will help us to monitor the response to treatment. So these are the investigations which can be performed in pneumonia in general. So as you can see here, this is a chest X-ray of a patient with a community-acquired pneumonia, in which there is the typical radiological findings of typical pneumonia, which is consolidation. There is right-sided lobar consolidation, which can be seen clearly, and this patient is indicating that this patient is having pneumonia due to typical organisms. And this is considered as lobar pneumonia because there is lobar consolidation. While in this X-ray, this patient is having another type of a community-acquired pneumonia, but this time there is no well-formed consolidation. As you can see, there are bilateral interstitial infiltrates. There are interstitial infiltrates bilaterally, and this indicates that the patient is having some sort of atypical pneumonia. There is an atypical organism which is involving the interstitium of the lung predominantly, sparing the air spaces. And for that reason, there is no well-formed consolidation as the first X-ray, and instead you will have bilateral interstitial infiltrates. Then let's talk about the prognosis of pneumonia. There is an important scoring system which can help us to evaluate the prognosis of pneumonia, and it can help us to evaluate the severity of the condition. And according to this scoring system, we can even decide the treatment of pneumonia. And we can decide whether the patient will require an outpatient treatment or an inpatient treatment, and whether the patient will require oral or parenteral therapy. This scoring system is called CURB 65 scoring system, CURB 65. C stands for confusion. U stands for uremia, patients with high urea, ideally more than 7 millimole per liter. R stands for respiratory rate 30 per minute or more. B stands for blood pressure, which is low blood pressure, hypotension. And eventually 65 stands for the age of the patient, 65 years old or more. Each one of these parameters will give you 1 point. And then you will calculate the total score of the patient, and according to that, you will classify the patient into either mild, moderate, or severe pneumonia. If you have a score of 0 to 1, it will be considered as mild pneumonia. If you have a score of 2, it will be considered as moderate pneumonia. If you have a score of 3 or more, it will be considered as severe pneumonia. And severe pneumonia is associated with the highest mortality rates. And then we will see in the management how we can use this scoring system in the treatment of pneumonia. So let's talk about the management of pneumonia in general. The management of pneumonia will depend on the category of pneumonia, whether it's community-acquired pneumonia, or it's hospital-acquired pneumonia, or it's aspiration pneumonia, because in each category there are specific organisms which can be causing the pneumonia. So for that reason, the antibiotic choices, the empirical therapy, will be different from each category of pneumonia. When you talk about community-acquired pneumonia, here in our antibiotic therapy, in our empirical antibiotic therapy, we will depend on the CURB score. It will depend on the severity of pneumonia. If you have mild pneumonia, which means CURB score 0 to 1, in these patients, you will treat the patient as an outpatient basis. So you will treat the patient at home. It will not require hospital admission because this is mild pneumonia. And you will give oral antibiotics since the patient is treated at home, so that means the patient will receive oral antibiotics. The choices will be either oral amoxicillin or oral clarithromycin. You use one of these two drugs. But if you have moderate pneumonia with CURB score 2, CURB score 2 means moderate pneumonia. Here the patient will require hospital admission. The patient should be admitted in the hospital. And then the patient can receive oral antibiotics, which can include oral amoxicillin plus clarithromycin. So in the mild cases, you will give one of these two antibiotics. You will give either oral amoxicillin or clarithromycin. But here, you will give both antibiotics. And you will give it orally. But if the patient is having vomiting and cannot take oral drugs, then you can give these antibiotics parenterally, intravenously. Then if you have severe pneumonia, which is defined as Kerb score of 3 or more, these patients will require hospital admission, but they should be admitted in intensive treatment unit. So moderate cases will require hospital admission, but moderate cases will be admitted in the general ward. They will not require intensive treatment unit. But here in severe cases, the patient should be admitted in intensive treatment units, like ICU, for example. And here you will give the patient parenteral antibiotic therapy. So the empirical therapy in severe pneumonia should be in ITU, in intensive treatment unit, and it should be parenteral antibiotic therapy. And it should include either IV co-amoxiclav, which is a combination of amoxicillin and clavulanic acid, or you can give IV cephalosporin antibiotic like cefuroxime, for example, or ceftriaxone. Cefuroxime is a second generation cephalosporin, and ceftriaxone is a third generation cephalosporin. And you will combine one of these two drugs with IV clarithromycin, which is macrolide. The reason why we are always considering macrolide in our management of pneumonia, because atypical organisms are sensitive to macrolides. Atypical organisms will not respond to beta-lactam antibiotic. It will respond to macrolide antibiotic like clarithromycin or erythromycin or azithromycin. So for that reason, our empirical treatment in pneumonia, in community-acquired pneumonia, should always include a macrolide antibiotic like clarithromycin. So in severe cases, you will give clarithromycin parenterally in combination with either co-amoxiclav or cephalosporins. So this is our recommendations in the management of community-acquired pneumonia. Then, after that, when we obtain the results of cultural sensitivity, we can modify our antibiotic treatment according to the results. And along with that, the management of pneumonia is not just antibiotics. Antibiotics are the specific treatment, but also there are other management elements. There are other elements in the management of pneumonia. For example, we should consider hydration of the patient. We can give intravenous fluids, because a lot of patients with pneumonia are dehydrated due to insensible losses and due to sometimes vomiting and diarrhea and poor oral intake. And so hydration is an important element in the management, in the general management of pneumonia. Along with that also, we can consider antipyretics for fever. We can consider also analgesic agents in patients with pneumonia who are having pleuritic chest pain, especially pneumococcal pneumonia. Along with that also, we should consider oxygen therapy. And not every patient with pneumonia will require oxygen. We will consider oxygen therapy in patients with pneumonia who are hypoxic. So oxygen is indicated in pneumonia in cases of hypoxia. And our aim is to keep the oxygen saturation 94% or more. Unless if the patient is having COPD, unless if the patient is developing pneumonia on top of COPD, in these patients are sensitive to oxygen therapy. They are at risk of hypercapnic respiratory failure. And in these patients with COPD, we should keep the saturation between 88 to 92%. We will give low flow oxygen, and we want to keep saturation between 88 to 92% in patients with COPD. But otherwise, we will keep the saturation more than 94%, and we will give oxygen therapy only when the patient is having hypoxia. Then let's talk about another category of pneumonia, which is hospital-acquired pneumonia. Here, the main difference in the management between hospital-acquired pneumonia and community-acquired pneumonia is the fact that macrolides, like azithromycin and clarithromycin, are not acceptable as empiric therapy. Instead, treatment of hospital-acquired pneumonia is centered around therapy for gram-negative bacilli. So as we said previously, the organisms causing hospital-acquired pneumonia are different than the organisms associated with community-acquired pneumonia. In community-acquired pneumonia, the most common cause is Streptococcus pneumoniae. And also there is a possibility of atypical organisms, which will be covered by macrolides. But here in hospital-acquired pneumonia, the most likely organisms involved here are gram-negative bacilli, including Pseudomonas. And for that reason, our treatment should be centered around therapy for gram-negative bacilli. We should give our empirical therapy should be directed against gram-negative bacilli. including Pseudomonas, because not every antibiotic will cover Pseudomonal bacteria. Pseudomonal bacteria will require specific types of antibiotics. So our initial empirical therapy for hospital-acquired pneumonia should always include anti-Pseudomonal antibiotic, an antibiotic which will cover Pseudomonas aeruginosa bacteria. There are multiple options of anti-Pseudomonal antibiotics. For example, we can give anti-Pseudomonal cephalosporins like cefepime or ceftazidime. Cefepime is a 5th generation cephalosporin, while cefepime is a 4th generation cephalosporin, while ceftazidime is a 3rd generation cephalosporin, and both can cover Pseudomonas. So you can give anti-Pseudomonal antibiotic in form of anti-Pseudomonal cephalosporin like cefepime or ceftazidime. Or you can give anti-Pseudomonal penicillin, like combination of piperacillin and tazobactam. Piperacillin is considered as an anti-Pseudomonal penicillin, and we will give it in combination with beta-lactamase inhibitor, which is tazobactam. This combination is called tazocine. Piperacillin plus tazobactam is called tazocine, as we discussed previously in antibiotics lecture. So piperacillin-tazobactam combination is considered as an anti-Pseudomonal penicillin, and it's one of the options which can be used in the management of hospital-acquired pneumonia. And then we have carbapenems. You can give anti-Pseudomonal antibiotic in form of carbapenems. Carbapenems like meropenem and imipenem, these are also antibiotics which can cover Pseudomonas infection. So the management, the empirical therapy for hospital-acquired pneumonia should be centered around gram-negative bacilli, and we should give anti-Pseudomonal antibiotic. All these three are beta-lactam antibiotics, as all these three examples of anti-Pseudomonal antibiotics are beta-lactam antibiotics. Beta-lactam antibiotics can include penicillins drugs, can include cephalosporins, it can include carbapenems. There are other anti-Pseudomonal antibiotics which are non-beta-lactam antibiotics. Non-beta-lactam anti-Pseudomonal antibiotics include aminoglycosides like gentamicin. Also, it includes fluoroquinolones like levofloxacin and moxifloxacin. So in the management of hospital-acquired pneumonia, sometimes we might use combination of 2 anti-Pseudomonal agents, not just one. We can use one anti-Pseudomonal drug belonging to the beta-lactam antibiotics, which include one of these 3 that we discussed. Plus, we can use also an anti-Pseudomonal antibiotic belonging to non-beta-lactam antibiotics, like fluoroquinolones and like aminoglycosides. But the main point here, in the empirical therapy of hospital-acquired pneumonia, we should always cover gram-negative bacilli. Along with that also, as we said, hospital-acquired pneumonia, the most likely organisms are gram-negative bacilli, but also there is a possibility of Staphylococcus aureus, including even methicillin-resistant Staph aureus. And so also, in our treatment, we should also focus and we should also consider antibiotic to cover Staphylococcus aureus. And we should consider the resistant type of Staphylococcus aureus, which is methicillin-resistant Staph aureus. And for that reason, along with anti-Pseudomonal antibiotic, we should also consider anti-MRSA, anti-methicillin-resistant Staph aureus antibiotic, like vancomycin. So this is our empirical therapy for hospital-acquired pneumonia. Then we have a special type of hospital-acquired pneumonia which is called ventilator-associated pneumonia. This is a type of pneumonia which develops in patients who are connected to mechanical ventilators, and it develops after 48 hours from more than 48 hours after connecting the patient to mechanical ventilators. The reason why patients on mechanical ventilators develop pneumonia is because the endotracheal tube used in these patients can provide an access for the oropharyngeal bacteria into the lower respiratory tract. So the oropharyngeal bacteria, it might colonize the endotracheal tube. And then after insertion of the endotracheal tube, these organisms will be introduced into the lower respiratory tract, and it can result in pneumonia. Along with that also, patients on mechanical ventilators are sedated, and they will have impaired cough reflex. They will have also impaired mucociliary clearance due to the sedation and due to the positive pressure used in mechanical ventilation. The patient will have depressed cough reflex and they will have depressed mucociliary clearance. And all these factors eventually will predispose the patient to pneumonia. And it tends to be severe pneumonia. It usually tends to be severe pneumonia caused by aggressive organisms, which can include the same organisms associated with hospital-acquired pneumonia, because it's a subtype of hospital-acquired pneumonia. So ventilator-associated pneumonia, more commonly caused by gram-negative bacilli, including Pseudomonas, and also it can include E. coli and Klebsiella, and also it can be caused by Staphylococcus aureus, especially methicillin-resistant Staph aureus. And for that reason, our treatment for ventilator-associated pneumonia should be almost the same as the treatment of hospital-acquired pneumonia in general. We should cover gram-negative bacteria, including Pseudomonas, and we should cover methicillin-resistant Staph aureus. So you will give a combination of anti-Pseudomonal antibiotic, like these, and as we said, anti-Pseudomonal antibiotics can include beta-lactam anti-Pseudomonal antibiotics, and we have non-beta-lactam anti-Pseudomonal antibiotics. So we can use each one of these three groups of antibiotics that we discussed here, and it will be combined with anti-MRSA antibiotic like vancomycin or like linezolid. Then after that also we have the category of pneumonia, which is aspiration pneumonia. And as we discussed previously, aspiration pneumonia usually involves anaerobic bacteria, which is part of the oral cavity. And so our empirical therapy for aspiration pneumonia should always cover anaerobic bacteria. And for that reason, we can use metronidazole or we can use clindamycin, because both are active against anaerobic bacteria. But along with that also, in addition to anaerobic bacteria, aspiration pneumonia also sometimes can be associated with aerobic bacteria. The aerobic bacteria which can result in aspiration pneumonia can include gram-negative bacilli, the same organisms which are also associated with hospital-acquired pneumonia, including even Pseudomonas sometimes. And for that reason, in addition to giving metronidazole, which will cover anaerobic bacteria, we should give also cephalosporin antibiotic, an intravenous cephalosporin like ceftriaxone or like ceftazidime, in order to cover gram-negative bacilli. And it's better to give a cephalosporin which will cover Pseudomonas. It will cover gram-negative bacilli, including Pseudomonas, like cefepime or like ceftazidime. So after talking about the diagnosis and management of pneumonia, before finishing our discussion on pneumonia, let's finally sum up our discussion and let's briefly compare between the typical cases of community-acquired pneumonia and atypical community-acquired pneumonia. We already mentioned the main differences during the lecture. Let's try to revise it. We can compare between the typical and atypical pneumonias according to the pathology, according to the clinical features, according to the laboratory findings, and finally according to the radiological features. When you talk about the pathology, typical community-acquired pneumonia, here the organisms will result in filling of the air spaces with exudate. So the air spaces in typical community-acquired pneumonia are filled with exudate. While in atypical community-acquired pneumonia, here the organisms and the infections preferentially involve the interstitial space of the lung, and more often it leaves the air spaces of the alveoli empty. So this is the main pathological differences between typical and atypical pneumonia. Typical pneumonia, it tends to fill the air spaces with exudate. It tends to involve the air spaces. While atypical pneumonia, the infection, it tends to involve the interstitium of the lung, and most commonly it spares the air spaces and it leaves the air spaces empty. And for that reason, when you talk about the clinical features, in typical community-acquired pneumonia, you will have productive cough. There is expectoration of sputum because the air spaces are filled with exudate. While in atypical community-acquired pneumonia, here you will have atypical presentation with dry cough. There is minimal sputum production, or even there is no sputum production. There is dry cough because here the air spaces are empty. The infection involves the interstitium, not the air spaces. For that reason, the patient will have dry cough. And this is atypical presentation because the typical presentation of pneumonia is with productive cough. And along with that also, part of the atypical presentation in atypical pneumonia, the patient might present with some extra pulmonary manifestations. As we discussed previously, in mycoplasma pneumonia, you might have some skin rashes, you might have some neurological disease or autoimmune hemolytic anemia. And in Legionella, the patient might have GIT manifestations or even acute renal failure. So atypical community-acquired pneumonia can give you extra pulmonary manifestations. Then also we can differentiate between typical and atypical pneumonia based on the laboratory findings. The typical organisms are detectable on sputum gram stain and culture, while the atypical organisms are not culturable. And that means these organisms will not grow on our standard bacterial cultures. They will not grow on our blood agars. So these are non-culturable organisms. And for that reason, they are considered as atypical organisms. And they will require special testing either with PCR, we can do sputum PCR, yani we cannot culture the organism, but we can detect the genome of the organism, the nucleic acid of the organism with PCR, or we can look for the evidence of the infection on serology. We should look for the antibodies formed against the infection, or we can look for the atypical organism antigen. For example, in Legionella, we can detect the Legionella antigen on the urine test. We can do urine antigen test for Legionella. So in general, typical organisms are detectable on gram stain and culture, while atypical organisms are non-culturable. Then finally, we compare between typical and atypical organisms based on the radiological findings. In typical community-acquired pneumonia, you will have consolidation due to filling of the air spaces with exudate. While in atypical community-acquired pneumonia, you will have interstitial infiltrates. You will not have consolidation because the air spaces are empty. And more commonly, you will have interstitial infiltrates, which indicate that there is inflammation and there is inflammatory reaction developing in the interstitium of the lung. And in a lot of cases, it tends to be bilateral interstitial infiltrates. So these are the differences between typical and atypical community-acquired pneumonia. So we'll continue our discussion in respiratory tract infections. After talking about pneumonia in general, now we will talk about lung abscess. And lung abscess is actually one of the complications of pneumonia. Lung abscess can be defined as a cavitating area of localized suppurative infection within the lung. And there are a lot of predisposing conditions which can result in lung abscess. In general, one of the predisposing conditions, we have inadequately treated pneumonia, and as we said, pneumonia can be complicated with lung abscess. So if you have inadequately treated pneumonia and persistent pneumonia, eventually, especially if it's suppurative pneumonia, eventually it can result in lung abscess. So it's one of the important predisposing conditions. And for that reason, it's important to diagnose pneumonia early and to start treatment as soon as possible. And you should not wait for cultures and sensitivity in order to prevent the development of complications like lung abscess. Then another predisposing condition is aspiration. So as we said previously, aspiration pneumonia, which is a form of suppurative pneumonia, eventually it can result in formation of lung abscess. So in a lot of cases of lung abscess, actually the organisms causing lung abscess are the same organisms associated with aspiration pneumonia. Then we have another important predisposing condition, which is bronchial obstruction. Bronchial obstruction due to any cause, it could be tumor, it could be foreign body. Any cause of bronchial obstruction eventually can result in lung abscess because bronchial obstruction will be complicated with recurrent pneumonia, and it will be complicated with recurrent suppurative and necrotizing pneumonia, which will eventually result in lung abscess. So always when you have a patient with lung abscess, you should do chest CT, and you can do also bronchoscopy in order to exclude any possibility of bronchial obstruction, which will require specific treatment. Then along with that also, lung abscess can complicate pulmonary infarction, another predisposing condition. Also it can result from septic emboli. So there is a focus of infection outside the lung, and this focus of infection resulting in septic emboli, and this septic emboli can result in lung abscess. The source of septic emboli causing lung abscess are always due to right-sided infective endocarditis. There is an endocarditis involving the right side of the heart, especially the tricuspid valve. And the vegetations which are formed on the valve, and we will talk later about infective endocarditis, the vegetations which will be formed on the right-sided valves, it can result in septic embolization. Part of the vegetation might break away and it might form septic emboli, and we know that the right side of the heart will open into the pulmonary circulation. And so that means these vegetations, eventually, it can go to the pulmonary circulation and it can establish an infection. These vegetations will act like metastatic infections, and it will establish an infection within the lung, and it will result in lung abscess. So septic emboli from right-sided endocarditis is an important predisposing condition for lung abscess, and it should be suspected in IV drug users. And in these cases, the the most likely organisms will be Staphylococcus aureus, because right-sided infective endocarditis is always related to IV drug users in which there is Staphylococcus bacteremia. So whenever you have lung abscess in association with right-sided endocarditis, the most likely organism will be Staphylococcus aureus, and most likely there is an IV drug abuse. Then also another predisposing condition, there might be extension of an infection, there might be extension from an adjacent infection like subphrenic or hepatic abscess. So all these are predisposing conditions for lung abscess. So always lung abscess will have a risk factor or predisposing condition. It will not happen spontaneously. The most likely organisms which are associated with lung abscess are anaerobic organisms. Anaerobic organisms are the most likely organisms involved in lung abscess, but also there is a possibility of aerobic organisms as well. Examples of aerobic organisms which can be isolated in lung abscess include Staphylococcus aureus, which is gram-positive aerobic organism, and also we have gram-negative aerobic organisms like E. coli, like Klebsiella, and even Pseudomonas. So lung abscess can be due to anaerobic bacteria, or it can be due to aerobic bacteria. Aerobic bacteria causing lung abscess include Staphylococcus aureus and gram-negative bacilli like Pseudomonas and like E. coli. And in a lot of cases, actually, there are mixture of organisms. You will have mixed organisms. You will have aerobic plus anaerobic bacteria involved in lung abscess. So what are the clinical features of lung abscess? As we said previously, any form of lung infection will give you fever and cough. So how can you differentiate between lung abscess and pneumonia and other types of lung infections? You need to look for a person with one of the risk factors that we mentioned here, one of the predisposing conditions. There is always a predisposing condition for lung abscess. Maybe the patient is already having bronchial obstruction due to tumor, or maybe the patient is having right-sided endocarditis, or maybe the patient is already suffering from aspiration pneumonia, or there is inadequately treated pneumonia in general. So there is always a predisposing condition, and the clinical presentation in lung abscess tend to be subacute or chronic. So look for a patient presenting with a chronic infection developing over several weeks, and the cough in lung abscess tend to be associated with large volume of sputum. So it's a productive cough, and there is expectoration of large volume of sputum that is foul smelling. So in lung abscess, you will have large volume sputum, which is foul smelling. These are the characteristic clinical feature in lung abscess. And this smell of the sputum is actually related to the anaerobic bacteria, which are commonly causing a lung abscess. And along with that also, because it has a subacute or chronic presentation, the patient will have weight loss. Weight loss is common. There is anorexia and there is weight loss, and there is also anemia of chronic disease, which will develop in these patients. You might also detect clubbing. And empyema also can develop in 20 to 30%. The lung abscess might open into the pleural space, and it can result in empyema, which is pus in the pleural space. And this happens in 20 to 30% of cases. Then let's talk about the diagnosis of lung abscess. Again, chest X-ray is the best initial test. In any form of chest infection, chest X-ray is the best initial test, and it will show you a cavity. It will show you cavitation in the lung, possibly with an air fluid level, but there is a wide differential diagnosis of lung cavitation. Lung abscess is not the only cause of lung cavitation. Other possible causes of lung cavitation include tuberculosis, include also bronchogenic carcinoma, also pulmonary infarction can result in lung cavitation. Pulmonary vasculitis, for example, in Wegener's granulomatosis, you can also have lung cavitation. Also in fungal infections, there might be lung cavitations as well. So there are multiple causes of lung cavitation. One of the possible differential diagnoses of lung cavitation is lung abscess. In order to have an accurate diagnosis, you need to obtain diagnostic specimens from the abscess. So you need to do bronchoscopy with transbronchial aspiration of the abscess for culture and sensitivity. You will not just depend on sputum culture, because the sputum can be contaminated with the oral flora, and part of the oral flora we have some anaerobic bacteria, and so this will not give you an accurate diagnosis. In order to have an accurate diagnosis for the cause of lung abscess, for the organisms causing lung abscess, you need to obtain diagnostic specimens from the abscess itself, and this can be performed with bronchoscopy. You will do bronchoscopy with transbronchial aspiration of the abscess, and then the specimen will be investigated with gram stain and with culture. Then the management of lung abscess. Lung abscess is one of the special types of abscesses in which the management is mainly medical. In abscesses in other sites in the body, for example, skin abscess or liver abscess, usually there is a major rule for surgery, surgical drainage or surgical excision. But in lung abscess, we will depend mainly on medical treatment with antibiotics. So we will give antibiotics preferably as indicated by sensitivities. So after we obtain diagnostic specimens, we will send for culture and sensitivity, and according to sensitivities, we will give antibiotics. And ideally, antibiotic therapy should be given for prolonged duration, and it should be for at least 4 to 6 weeks. But initially, before we obtain the results of the sensitivities, we can give empirical therapy, and our initial empirical antibiotic therapy should be directed against the most likely organisms. And as we said, lung abscess most commonly is associated with anaerobic bacteria. So our empirical therapy should include antibiotics which will cover anaerobic bacteria like clindamycin and like metronidazole. And also we should give other antibiotic which will cover aerobic bacteria like gram-negative bacilli and like Staphylococcus aureus. So our empirical antibiotic therapy should cover both aerobic and anaerobic bacteria. The antibiotics that should be used to cover anaerobic bacteria can include metronidazole. It can include also clindamycin. Clindamycin is one of the good options to cover anaerobic bacteria above the diaphragm, like in lung abscess. But the problem with clindamycin, it's strongly associated with pseudomembranous colitis. And for that reason, it's less commonly used in practice. So you will give empirical antibiotic therapy, and then you will modify the treatment according to the sensitivities. And you will continue the treatment for the total duration of 4 to 6 weeks. In cases of unresolving lung abscess, the condition refractory to antibiotic therapy, then we can consider surgical options as part of the management. Along with that also, as part of our workup, we should always, in addition to doing chest x-ray, we should do chest CT and we should do bronchoscopy in order to exclude bronchial obstruction, because there is possibility that lung abscess is secondary to bronchial obstruction caused by bronchogenic carcinoma. So always when you have a patient with lung abscess, try to exclude any possibility of bronchogenic carcinoma. As you can see here, this is a chest x-ray of a patient with lung abscess. It's showing lung cavitation within the lung with air fluid level. And there is, as you said, there are multiple conditions which can give you lung cavitation. Lung abscess is one of the possible differential diagnoses.